Hello, I'm Mary Ito, and welcome to the CRAM podcast. CRAM is an acronym for Communicating Research and More, which is what we try and do on this podcast. A lot of exciting research and groundbreaking ideas never reach the public, but they have the potential to change the way we think and act. Well, one of our most popular podcasts from last year was about a subject that we are all too familiar with, pain. As they say, you can't live with it and you can't live without it. Unfortunately, there are many people who live with constant pain, and there is little, if any, relief for them. Dr. Andrea Furlan has made it her life's work to research the mechanisms of chronic pain and what actually works to alleviate it. We've asked her back on the podcast because she has just released a brand new book. It's called 8 Steps to Conquer Chronic Pain, A Doctor's Guide to Lifelong Relief. Andrea Furlan is a staff physician and senior scientist at the Toronto Rehabilitation Institute, scientist at the Institute for Work and Health, and associate professor in the Department of Medicine at the University of Toronto. So nice to have you back, Andrea.
Well, thank you, Mary, for inviting me back.
So the title of your book, it says 8 Steps to Conquer Chronic Pain. I think myself, that's a pretty bold statement to make. I'm not sure if you came up with it or your publisher. So I want to know, is it actually possible to conquer chronic pain?
Oh, yes. The title is bold because it is possible. And I wrote the book because I saw so many people conquering their chronic pain that I said, more people need to know about this. They need to know that there's hope, that they can do it. Conquering chronic pain doesn't mean sometimes that the pain will go away completely, but it means that you can live a fulfilling life, do everything you want, despite having this terrible symptom, which is constant, ongoing pain.
Well, Andrea, I think people would love to believe what you're saying, but they might be skeptical because if they have chronic pain, they might have seen many doctors, received all kinds of treatments, perhaps surgery, pills, exercises, and they're no better off. So first of all, why is that such a common scenario?
It's very common. And people come to me, they have years and years. They tried a lot of things. And that's probably because they were looking in the wrong place. Looking for all of those pills and injections and things done to them is not how you probably conquer chronic pain. Conquering chronic pain, it has to come from inside of you. So it has to be a shift in how you understand pain, how you interpret pain, what you do for yourself, what you can we call this self-management. And self-management means what are the things that they will be doing? And I also talk about a toolbox a lot. The toolbox are the tools that they put in their box of self-management. And when a person is free from seeking a cure or seeking another injection, another surgery, another treatment, another pill, they realize that anxiety of seeking what is wrong with me, when it goes down, that actually relieves a lot of the chronic pain because they are connected in the brain.
So if you say that the answer lies more within us, right, rather than without us, rather than externally, is a big reason because pain is subjective. And so, because I remember in the book even, you said that you've never seen two individuals with exactly the same presentation of pain.
Yeah, so pain is all subjective. And because pain can be, it's an interpretation of something that is happening, you can change that interpretation. So for example, if a person, I just saw a patient this week like this, a person has arthritis. Osteoarthritis can be very painful. But the problem that I saw this patient this week, she was told that her bones were terrible. The doctors told her that this was a terrible arthritis in all of the joints of her body, that the x-rays were horrible, that she would get worse, and this would never get better. She would need surgery replacement in her whole body. And then she believed in that. And because she wanted me to repeat MRIs every 6 months to see if the osteoarthritis was getting better. And I told her, no, it's not going to get better, but you don't need to be in pain all the time. So what we teach the person is, even though their bones might be having arthritis because it's a destruction of the joints, there are a lot of people who live with that and they don't have any pain in their joint. Yeah, it's amazing. Most of the people, if we x-ray people who don't have any pain at all, or MRIs, you're going to find a lot of abnormalities, and they don't have pain.
Okay, let me just, let me make sure I understand this. You're saying that there's not necessarily a correlation between what you see on an MRI or any other kind of scan and the level of pain. That's what you're saying.
You got it. That's totally true. So what we need to do is, I told this, and I tell this all my patients who come with terrible MRIs and x-rays, I say, I'm not going to treat the paper. I need to treat you. I'm not treating this piece of paper. And the example that I give, I always tell my patients the story of my grandmother. She had a terrible, I think the most horrible x-ray that I've seen, because she was 92. Her neck, one day she fell and someone decided to x-ray her neck, but she never had pain in her neck. Never in her whole 92 years. But it was the most horrible x-ray that I've seen my whole life. There was no disc, no space. The nerves were all compressed, and never she had pain in her neck. Never. So I think people need to understand that if you're having pain in a joint, in a piece of your body, a place of your body, first of all, we need to understand examining that part to see if, when we do the physical examination, that's why they need a good doctor, a good person to examine them. They need a pain diagnosis. And then if they examine that body part and they say, this is functioning okay, you can walk, even though you have what looks like an arthritis, because we all have some sort of arthritis in our body. But they say, you can move, you can do anything you want. And the person starts moving. Motion is lotion. It's unbelievable what they can do. And doing exercises in the water, like a pool, aquatherapy, hydrogymnastics, is amazing, because it's not only good for the joints, but it's also good to produce endorphins, which is our endogenous opioids.
Yeah. And see, it's interesting too, because what you say, for some people, that's counterintuitive, because they feel, oh my goodness, I'm in so much pain. I can hardly move. I'm not going to move. I'm just going to take it easy and rest here.
That's called fear avoidance behaviors. And we have part of the treatment of chronic pain is to make them understand that they are having this fear avoidance, and that they can move, that they can do things, and stimulate them, motivate to do it. Because once they start retraining their pain system, which is part of the treatment of chronic pain.
Right. Okay. Just before we get into some of the 8 steps that you have, I think maybe it's important that you actually describe what chronic pain is, because I think for many people, they think it's something physical that they can actually see on an X-ray or an MRI or something.
And for some people it is. Some people will be, they will have like a tumor, and that's irritating a nerve. It might be an arthritis that is actually pinching a nerve. It might be a compression of a nerve in the spine or peripheral. So there are 3 types of chronic pain. Chronic pain is defined as ongoing, constant pain every day for at least 3 months. But actually, when people come to me, they have this ongoing, constant pain for 3 years, 3 decades. And the 3 types of chronic pain, the first one is there is something irritating. There is a disease there. There is inflaming, right? And it could be that there is when we talk about the alarm system of the house, the alarm is making noise because there is a fire there. So you need to go there and put up the fire. The second type of pain is neuropathic pain, when there is some nerve damage, nerve injury, nerve disease, like multiple sclerosis can cause chronic pain, because There is the myelin of the neurons. They disappear. So there's pain because of that, spinal cord injury, pain after a nerve compression like a carpal tunnel syndrome. So those are neuropathic pain. And there is a nerve pain. The nerve pain is different. It's like burning, electrical shocks, tingling, numbness. Now, the third type of pain is when the alarm system of the body is malfunctioning. So there is no fire. There is no short circuit in the body anymore. And the alarm system is going on, making that noise when there is no fire anymore. In this case, that's when we need to stop searching for a cure that is in the periphery. The problem is not in the knee, in the spine anymore. The problem is in the pain system. And where is this pain system? The pain system is everywhere. It starts in the periphery with the receptors, the nerves, the spinal cord, the brain, the emotions, the thinking, the neurological system, but also the immunological system, and even the hormones. It affects the hormones. So that's why chronic pain is a disease of many systems. And the person feels fatigued, concentration is poor sleep, they don't have energy, because it is a disease of many systems.
So for that last one, for the nociplastic pain, where there's not actually something like physical that's identifiable, is that the hardest to treat?
No, sometimes it's the easiest.
Interesting.
Yeah, sometimes it's the easiest, because it's not that, and I don't like to say, let me clarify something here. It's not that the person is imagining the pain. No.
Oh, because people do get told that.
Yeah.
Oh, it's all in your head. We can't find anything on the x-ray or anything.
It's not. It's a real pain. And it's just that the abnormalities are not in the periphery. There are abnormalities that we can see in laboratory. We can measure in laboratory, not in the clinic. And we can measure and we can see in function MRI. So there are alterations in the pain system. It's just that it's here in the pain system. It's not in the periphery anymore. And the person is not imagining, and the pain is very real, and it's constant, and it's annoying. And the person looks normal because they have nothing to show. So it's invisible.
Yeah. So I can see that if a doctor is looking for some kind of actual like physical proof, they're going to be frustrated by that, right? Because they're not going to find it.
Yeah.
They're just not.
That's why they go 30 years trying a lot of things, and 30 years later they still have pain.
And can I ask you, so if the damage or if the breakdown is happening somewhere in the pain system of the body, right? Is that really difficult to identify, to target where that is? Is it almost impossible?
No, it is. I would say the difference here is also like hardware and software. So if you have a computer, you understand hardware is what would be the nociceptive and neuropathic pain. So there's something broken. Your computer is not working because, boom, it crashed in the floor and broke. So you can see that it's broken. Now, your computer may not be working because there's a software problem. So that's nociplastic pain. So you can't see what is wrong, but the computer is not working, and you need to change the software. So there is a problem. There is a real problem. The problem is not in the hardware. It's in the software. So you need to maybe reinstall your software all over again. So you need to do something. You need to do a therapy. It doesn't mean that it's just going to disappear by itself. But I would say that it's interesting, Mary, that they say that it takes 17 years for research to reach clinical practice. This research is more than 20 years old. So it's taking more than 20 years for this to make clinical practice. We know that for 20 years that this nociplastic thing, where it is and where it's happening, more advanced has been happening. Oh my God, in the last 20 years, a lot has happened and we know much more. But this nociplastic pain is not secret. It's not hidden somewhere that is so difficult to find. It's just that if the doctors and the patients start looking and open your mind and think, is this possible? Maybe, is it possible that I have nociplastic pain? Open the possibility. Start reading. Start looking for information in this area, and find people that work with the mind and body, because the treatment is basically connecting the mind and the body and training your pain system. What is normal pain again? That you are not on fire. You are not in danger. That's the first thing.
Well, you know what? So yeah, that's your first step is about retraining, I guess the way you deal
Yeah.
with your pain, right? And to me, that sounds to me to be one of the most important
Yeah.
steps. But how do you do that? I mean, how does someone actually retrain their pain
Yeah.
system? It sounds like monumental.
Yeah, there are many different techniques. Mary and I talk about this in the first chapter. There are different techniques. There are things that have names like commercial names and people who invented like a package and they then put a name on this thing. And so this could be treatment, and this could be things like a couple of weeks of therapy session. And this therapist, it's someone who understands this pathophysiology of the pain. What is
Right.
nociplastic pain? So they have to be someone who understands what is nociplastic pain. Make sure that the patient has almost everybody with chronic pain will have some component of nociplastic pain.
Mm.
They may have more than one type. They may have nociceptive and nociplastic, neuropathic and nociplastic. And removing the nociplastic component helps a lot their quality of life. So these therapists that train in doing treatment for nociplastic pain, they are people like physiotherapists, chiropractors, occupational therapists, social workers, nurses, some physicians, psychologists, who will then help the person do exercises for the mind and exercise for the body. So, for example, I'll give some examples. A person that has, pain for many years and was told that they have arthritis and they may have some disc bulges in their back, a lot, normal, and low back pain, chronic low back pain. So the first step would be asking them to move and see what happens and show this person that there are positions that they are that may not trigger the pain. There are positions that they are that trigger pain. And when they have this connection, every time I use this chair, I have pain. That might be a condition, the Pavlovian response. Yeah. That in your brain, kind of you are trained. If I sit in that chair, I will have pain. So every time you look at the chair and you already have pain. So they will help the person to disconnect that synapses. They will say, I want you to sit in that chair. I want you to be in that position. I don't want you to suffer. The thing is not, I don't want you to go through pain and suffer pain. I want you to understand that your body is okay. You are not in danger when you sit in that chair. So the person will sit there and they will do some breathing exercises. They will calm down their mind. And once the person realizes, oh, okay, I'm not broken. My spine is actually okay. I may have that disc bulge, but that may not be caused because there are so many people who have disc bulges and they are walking down the street and they have zero pain. Why is mine hurting? It's because I made that connection. I made that condition in my brain. So once they sit in that chair and they experience 10 seconds without pain, they disconnected that synapses. That's done. They don't have more pain when they sit in that chair.
Okay, so is what you're doing, because you did say in the book that chronic pain actually changes the brain.
Yeah.
So if let's say someone's had that for decades, is it the fact then that their brain has changed and they're always going to that same path of pain over and over?
It's memory.
And then what you're doing with this treatment, with this mind-body connection, you're creating a different route.
Yes.
That doesn't involve pain. Is that what's going on?
It's memory. We know now that the same, how you learn something. Yeah. And the more you practice, let's say you learn driving a car. The first time you drove your car, you were very nervous because those synapses were not made yet. And you could not even listen to the radio. You had to pay attention fully to what you were doing because you were creating the synapses. But now, many years after you drive, you can drive in autopilot. You don't even, right? Because those synapses are so strong. The same thing with pain. So if the person reinforces that synapses day after day, that synapses gets stronger. It's the same mechanism. It's called long-term potentiation.
Okay, so then if that's true, would it also be true then that the longer that you've dealt with chronic pain, there's more of a chance that it will be more difficult to get rid of that because you've carved
yes
that path
and
for
no.
over so many years.
Yes
No?
and no, because the brain is so amazing. I've seen people who had pain for so many years. I will give another example. This lady, I can't remember now her age, 70, 80. And she came to me because she was taking painkillers and osteoarthritis in many joints. And she's, not a candidate for knee replacement, hip replacement, or the whole body replacement. And then I explained this to her. And I told her, can you get into the water? Because if you move inside the water, you will be moving your whole body. Mm-hmm. She came to me a couple of months later just to say thank you and goodbye.
Those are the words you want to hear. Yeah, thank you and goodbye.
Because she said, when I go in the pool and I go in the hot water, and then when I am there, I don't feel pain. And I still have the arthritis. And she said, she made that connection because she said, once I get out of the pool, because when she was in the pool moving, she said, I don't feel pain. And then she gets out of the pool and she still doesn't have pain. And then she said, but listen, my arthritis is still here. It didn't go away. So what Dr. Furlan said, it's right, because now I'm not feeling it. So what she learned, how to use those moments. She said, what's going on in my mind right now that I'm not feeling any pain? She was happy. She was full of endorphins in her body, probably because when you exercise, you produce a lot of the happy hormones, your own opioids. She was motivated. She was, how can I say? She was satisfied with herself. She was proud of herself. And she said, how can I increase those moments in my life? And I don't need to be, suffering from pain, sitting on the couch all day. So what she did was more distraction in her life. She lost a little bit of weight, not too much, a little bit. She started walking, meeting friends. And she said she needed to go to the pool every day. But it's okay.
Because it worked for her. Wow. You know what? So that actually leads me to your second step. You talk about how important it is to control your emotions. So what do emotions have to do with pain?
I'll give you another example. I like to give examples because that clarifies.
They're great.
I have lots of patients, including people in my family, who say, when I travel, I went to Europe, I went to Greece, I went to Italy, I went to Japan, whatever. I think the air there or the water there was so good. It's better than because my pain disappeared.
Yeah, I've heard that too.
No, I use that example to tell my patients, actually, you brought your pain with you because your body is the same, but you left your problems at home here. So then I teach them, I say, okay, good. You gave me what I needed to teach you the step number 2, because what happens is when you were there, your problems still happen. Your worries, your angriness, your frustrations, they are still present, but you are not pay attention to them there. That's why your pain got so much better. And now you need to do the same thing here. And so I teach them to be in that state of mind again. It's possible. And I say, they can do self-hypnosis. They can do mindfulness. They can do meditations. They can do prayers. They can read a book. They can do virtual reality. They can go play a video game. They can go volunteer and help someone. Those are all healthy things that they can do for themselves. But some people, they do need a psychotherapist, a psychologist, because those emotions are really affecting them and they need someone to talk to. Sometimes they need to take medications because those emotions might be dangerous. They're thinking about, damaging themselves, hurting themselves or someone. So some people will need help. But most people can realize that emotions are a big part of our pain and they affect a lot how we feel, how we interpret pain.
Well, you raise another good point about maybe some people do need to see a therapist. Yep. Would there be a higher rate of depression among people who have chronic pain than the normal population, the regular population?
Anxiety, depression, sleep problems, loneliness, social problems. marital problems, relationship problems. They stop working, so they have either work-related problems, like their productivity at work might be less, or they lost their job and now they have financial problems. Yeah, so it is a big thing.
Yeah. It strikes me from everything you've said that this whole like psychological area of treatment, the psychological component, it is so important, right? I mean, it's just as important as the physical, maybe even more important for some people, the psychological. If that's true, and you want people to do these kind of mind-body exercises and to sort of imagine themselves in a better place, they really have to buy into this, don't they? I mean, they really have to believe that this is going to work.
That's the main barrier, Mary. When I start talking about this to my patients, they say, oh, listen. Are you going to tell me that I'm imagining this pain's in my head and I need to say psychologist and thinking differently, my pain will go away? And then many of them disappear from my clinic. I feel sorry for them because I probably will see them 10 years later and they are still trying to look for a cure.
Do they think, do any people think, oh boy, I think, she's out to lunch. She's a bit wacky here. I don't know what she's telling me.
I hear this and I get angry, frustrated patients that, they don't buy the idea. But what can I say? There's science behind it. I tell them I didn't invent this. I'm just the messenger here.
You're the messenger.
I'm the messenger. Don't shoot me. I'm just the messenger. There's a lot of science behind it.
And I do now, I want to address the area of medications because I would imagine that there are a good number of patients who come and see you and they expect to get drugs from you, right? And so, and it is a huge area, right, of medications to treat chronic pain, and especially opioids. But I was interested in reading in your book that you said you actually prefer to treat chronic pain without medications if possible.
Yeah,
right. Possible. So tell us, when are medications warranted?
Yeah, of course. I love them. I love prescribing medication because if it's for the right patient, if the patient has a nociceptive or neuropathic component, prescribing medication will give them a lot of pain relief, 60, 70, sometimes not 100% pain relief. And that's so satisfying for me because I want to help them. I want them to say, oh, thank you, doctor, for that medication. It really helped. The problem is not a lot of people have that nociceptive. And I look, Mary, I am desperate. When I examining the patient, I'm always trying to find like something in the periphery, something that is broken in the hardware, nociceptive, neuropathic, because that would be easy for me to treat with an injection, pill, a surgery. Okay, I want to find that. But when I don't find, and the pain is nociplastic, then no medication will eliminate the nociplastic pain. We can help them there are some medications that will help them if they are so depressed that they need antidepressant, or if they have a mixed pain, a neuropathic and nociplastic pain, that I need to give some anti-neuropathic pain medications. Those are anticonvulsants, anti-epileptics, even cannabinoids or opioids. If they have some inflammation that is really destroying the bone or the nerve or compressing, and I can see the inflammation, that they need anti-inflammatories or biologics for rheumatological conditions. And this is great. So my preference is, if I can avoid the medications, because once you put these people on medications, basically you're putting them for life. Right? Because chronic pain is a chronic disease. And some medications have side effects like weight gain.
Yes.
They may, have a problem to be too drowsy, nauseated, constipation, addiction to these medications if they are cannabinoids or opioids. So you really need to think about, do I really want to put this person on medication? Because who is going to stop? Once they start, who will be, able to stop? I see a lot of patients who are taking multiple medications. This is polypharmacy, and many family doctors refer them to me because they don't even know which ones they can reduce, taper, deprescribe. And I have stories that are horror stories. People were taking multiple tablets I don't even know how they were swallowing, because it was almost like a bowl of cereal equivalent of how many tablets they were taking per day. And I don't even know how their stomach was handling all of that. But then we help them to reduce one by one, reducing the dose, eliminating them. And people tell me at the end, when we reach a stable dose or we were able to eliminate many, they say, I don't know why I was taking all of those medications, because I have the same pain right now, or even the pain might be even a little bit better, but I don't have all those side effects. I hear this a lot in my deprescribing clinic.
Yeah. Would part of the reason, I mean, we mentioned earlier the fact that, there may be some doctors who just aren't aware of this approach, right? And they think that the medication route is the way to go. But this might sound a bit cynical, but medications are also easier to prescribe, right? What you're doing takes time.
Yeah. Yeah.
It takes a lot of time, and, you just write out a prescription, done. So I have to think that's a factor as well.
Yeah, of course. And the doctors want to help, but they also, family doctors are the ones who are seeing most of these people in the community. And very few people have access to a pain specialist like me. They wait months to see me.
Mm-hmm.
And the family doctors, they have 5 minutes for each patient. They don't have time for all of this. You're right. And not only this, but if they send the patients to a specialist, the specialist may also add another medication, send back to the family doctor, and the family doctor will just keep prescribing for the rest of the patient's life, because they don't know how to question or to, counter argue with the specialist who started it.
Mm-hmm.
So they go to they go to the orthopedic surgeon, to the rheumatologist, to the physiatrist, to the neurologist, to the anesthetist, and each one of them adds a different medication to treat pain. And suddenly the patient is taking an irrational number of pills.
Yeah. And probably some of them aren't even working any longer, or might even be detrimental to them.
But they're afraid
right?
of stopping, because they're afraid of stopping what's going to happen to the patient.
Some of the other steps you talk about in the book, they make sense to me about getting good sleep, because I know when I don't even sleep well, I feel sick. Like, I don't feel good. So I can only imagine if you have chronic pain, you must feel worse. So, of course, getting quality sleep, having a good diet, a good nutritious diet, that makes sense. And also you talk about, you should be able to lean on other people, right? Like family, your friends, your colleagues, and even support groups.
Yeah.
You find those are helpful?
Very helpful, Mary, because chronic pain is a invisible disease. Chronic pain it's very individual, so subjective. And they feel so lonely. They feel that other people don't understand them. And that makes the pain worse. So the thing is, if the person doesn't have support, they don't have anyone who understands, or they can't even talk to the doctor because the doctor, sometimes they don't want to listen, that makes the pain worse, actually, because the brain will now be in high alert. The brain will be anxious. There will be release of stress hormones. They will be worried about this. And guess what? That will feed the loop in the brain, and it will cause more nociplastic pain. So we do need to work on those connections, personal connections, and support groups are great. I don't recommend some groups to people. I say, be careful which group you join. But there are very healthy groups that are led by people who overcame their chronic pain. They still feel pain, but they know how to do self-management. They know all these steps, inside out, upside down, all the way. And they will guide the other person to do this, because even to tell you the truth, I don't have time. After a consult, I spend an hour and a half with a patient trying to investigate what is wrong with this person, examining. And then at the end, the person is tired. I am tired. And I would like to explain the whole book to them, but I don't have time. So if they can find a peer support group that they can discuss those things, I heard this, my doctor told me this. What does it mean? How do you do it? What did you do with that information? What do you do if you have a flare up? That is it's like Alcoholics Anonymous. They need that ongoing support. They need people who lived the problem, found the solution to guide them again.
So, where do you think your book fits into, I guess, the whole treatment plan of someone who has chronic pain? You know, what role can your book play?
Yeah, I wrote the book because, first of all, there is a lot of knowledge, a lot of advancements, and many people with chronic pain, they have no idea about these things that are in the book. So I think this is a good start if a person had been diagnosed with chronic pain. If there is a caregiver, someone who cares and is worried about another person who has chronic pain, they can also read the book to help that person. I also find that many healthcare professionals don't understand chronic pain. Doctors, nurses, physiotherapists, they may also benefit. Although the book was written in lay language for the public, I think they may benefit from understanding what goes in the mind of these people, how they can help. There are a lot of resources that I put in the book that they can point to the person that is having and suffering from chronic pain.
Well, what do you think is the most important message that you want people to leave with?
It's possible to live a good life with chronic pain. There is hope. They don't need to lose their hope, because when they come to me and to many pain clinics, they are at the end of the hope. They say, I tried everything. What else can you offer me? You are my last resource. And I don't think there's anything else that I didn't try in this world that will work. And I tell them, there is hope. Don't lose your hope. That you are going to find something that will work for you. And maybe in this case, just start understanding what is chronic pain. You cannot beat chronic pain if you don't understand what you are against. You cannot conquer the mountain if you don't study the mountain. It's a mountain in front of you, okay, but it is possible. So study it really well. Like a mountaineer, that's the analogy that I use in my book.
Yeah.
The mountaineer that decide, I'm going to climb that mountain. And they study that mountain, they prepare, they buy equipment, they get people around them that will help them climb the mountain. And then they decide, I will go. And then one day they start climbing. There will be good days and bad days. There will be rainy days, cold days, hot days. They will get hurt maybe in that journey. But if they keep going a little by little, one day they will get there. That's my message of hope for everyone who is suffering from chronic pain, because 1 in 5 adults have chronic pain.
Wonderful, wonderful conversation, Andrea, as always, and just a fantastic book. I'm so glad that you came out with this book and put, all this knowledge and experience and the people that you've helped and the people you've worked with all into one book. So thank you so much.
Thank you, Mary.
That's Andrea Furlan. She is a staff physician and senior scientist at the Toronto Rehabilitation Institute, scientist at the Institute for Work and Health, and associate professor in the Department of Medicine at the University of Toronto. She has published this wonderful book on pain management. As I said, she's put all her experience and expertise into it, and I do hope you enjoy it. For more information on her work and research, check out our show notes. That's it for this edition of the CRAM podcast. Our thanks to the Temerty Foundation for their generous support. And please, if you can spare a moment, give our podcast a rating. It would really help us. You can follow us on social. Our handle is @CRAM Ideas. Thanks for listening and your support, and see you next time.